Good morning, ladies and gentlemen. It's a great honor for me to speak in front of you, and also congratulations, KSERS for the 30th anniversary. Today, I'm going to talk about the key steps of a minimal invasive liver surgery. So, when I think about the minimal invasive surgery, I think like we're limiting ourselves too much. Like we're drawing the lines, we confine in there, we cannot go outside. So there is a Bannister's effect. That is the guy, Bannister, in 1954, before him, 4-minute mile barrier, which was previously considered impossible by many experts. But once he broke his record, about 2 weeks later, another guy broke his record, and in about 2 years, dozens of other runners achieved less than 4-minute miles. So the limitation was largely mental, not physical. Once the belief that it was impossible was shattered, others could achieve it. So I'm going to talk about what kind of a limitation and barriers we have and how we can overcome those. So I slightly changed my topic, the key steps for expansion of a minimal invasive liver surgery. So this is my disclosure. Today I'm going to talk about the safety check and how we can expand MIS surgery in liver. First topic is the robotic hepatic artery infusion pump, and second is the schistotripsy. So always we have to, before we expand our criteria, we have to check whether it is safe or not. And also we have to have an emergency plan and assign the role in the OR, simulation drills yearly or biannually, including anesthesiologists, nursing staffs, and assistant. And also we have to prepare the equipment like a laparoscope instruments, open conversion kits, what kind of gauze or surgical biosurgical material, and sutures, etc. And not just jump it into the open, we have to control the site, compression or packing until the other team is ready. And also communication is key for the success, like vitals and blood availabilities and call for the help. Why I'm talking about the hepatic artery infusion pump. As you can see, this kind of colon cancer liver metastasis is not a surgical indication minimally invasively at the time of diagnosis. This type of treatment is a systemic chemotherapy. Once the patient got chemotherapy, that seems to be resectable. So if the resection happened for the colon cancer liver metastasis, if the patient get the hepatic artery infusion pump, their survival is much better than just simple chemotherapy. So hepatic artery infusion pump that provides convergent therapy, that meaning unresectable tumor to the resectable, and also that provides adjuvant chemotherapy, sometimes that could help palliation cares. Good thing for the hepatic artery infusion pump is they could deliver more than 400 times higher concentration of a chemo agent through the hepatic artery. This is GDA, then common hepatic artery and the prehepatic artery. Both common and proper hepatic arteries clamped, and arteriotomy was made, and catheter was inserted through the GDA. Once the GDA is inserted, we inject the methylene blue you can see the change of colors of the liver by dye. So hepatic artery infusion pump also can provide bridging treatment for the liver transplantation. So unresectable colon cancer liver metastasis, if the patient get the liver transplantation, their survival is much better than just simple chemotherapy. As you can see, the outcome is over 30% of overall 5-year survival, but the problem is 74% recurrence rate. Then how we can reduce the recurrence? This is our solution for the reducing the recurrence rate. So basically, we minimize the disease burden with the liver-directed treatment, and also sometimes they could cause hepatic failure. However, if we could aggressively downstaging the tumor, that helps. So our goal is mainly minimize the tumor burden and make the metabolic tumor volume almost get to the 0 point. So in our study shows aggressive pre-transplantation liver-directed treatment that helps the undetectable disease, and also that could help the preventing the tumor recurrence. In our Cleveland Clinic protocol during 2017 to 2005, we included 47 referral for the potential transplantation. 42 was considered intensive liver-directed therapy, and 22 patients received the liver transplantation, and 9 patients is receiving our protocol, and 5 was dropped out due to the disease progression, and 4 declined due to the medical surgical reasons, and 3 patients was dropped out the patient decision. So as you can see here, there is our liver-directed therapy. 7 patients was including hepatic artery infusion. So once the patient have aggressive downstaging treatment that increase the recurrence-free survival up to 82%. Interestingly, 5 out of 7 who had a hepatic artery infusion pump, there was no residual cancer. So hepatic artery infusion pump can provide the superior survival outcomes, and also that is excellent local disease control and great liver-directed treatment for the liver transplantation. So I'm going to talk about the histotripsy. So I'm going to talking about a little bit of physics. So when you are in the high school, you may remember the water can vaporize in the very low pressure. Everyone knows that water is boiling on 100 Celsius. But even for the lower temperature, when the pressure is low, the water can vaporize. So this air bubble can generate in the water in high speed and low pressure that happening cavitation. The cavitation can erosion. This is the same principle as a CUSA. Again, ultrasound can generate the pressures. Once that goes up, the pressure, sometimes the reciprocally that refraction can happen. That we can control the pressure with the ultrasound. Everyone well-known HIFU is a continuous wave that is a low amplitude, that continuous waveform that generate the heat. But histotripsy is different. It's a high amplitude but that is causing cavitation that causes a microbubble. This picture shows the continuous HIFU generating the heat in the central area. However, the histotripsy, you can see that the microbubble that generated by the ultrasound, but it doesn't cause any heat. So this is a commercialized platform for the histotripsy. Because this is a water ultrasound-based treatment, have a water basin, and you can see that the tumor is grinded by the micro bubble cloud. That it doesn't cause any heat, thermal injuries, and it doesn't require any incisions. This is the tissue in the water. You can see that the tissue is grinded by the histotripsy. Once the tissue is grinded, you can see that the liquefied tissues. Good thing for the histotripsy is that preserve the collagenous tissues, including veins, vessels, and bile duct, and liver capsule. That's a pilot study was done, published in 2025 that included 19 patients with a hepatocellular carcinoma patient and 11 colon cancer liver metastasis, and also they include 28 patients with the metastatic diseases. That study shows over 90% of a local control rate, and there was a very minimal adverse effect. And over 73% of a hepatocellular carcinoma patient was survived more than 1 year, and over 48% patient was survival with the liver metastasis patient more than 1 year. So interestingly, about 40% is the interventional radiologists using this platform, and about 50% of the surgeons actually using this platform in the United States. So far, over 4,000 cases been done by histotripsy, and main indication of a histotripsy was colon cancer liver metastasis, and hepatocellular carcinoma, and cholangiocarcinoma, neuroendocrine tumor, and pancreas cancers. This is a worldwide distribution of a histotripsy. The mainly United States utilize this platform. So this is our Cleveland Clinic experience. We adopted the histotripsy December 2023. So far, we did over 200 treatment, over 150 patients. Most common indication was colon cancer liver metastasis, and breast cancer, and pancreas, and neuroendocrine tumor, and hepatocellular carcinoma. So this treatment is, we can apply for the radical treatment, like other ablation treatment, like 3.5 centimeter is an optimal size of the tumor. And also we can use it for the bridging treatment, and also sometimes we can use it for the palliation treatment. So we published the bridging therapy for the liver transplantation, the patient who had a hepatocellular carcinoma. This patient's BMI was 55, and this is tumor in the segment 2. That's a preoperative CT scan. After histotripsy, post-op day 1, we routinely have a CT scan, which shows the necrotized tissue. In about a month later, patient got an offer, deceased donor liver transplantation. That was an explanted liver. You can see there was not remarkably, we cannot tell well what's happening, and this is the new liver. So final pathology shows the untreated lesion shows just cirrhotic nodules, but in the treated area, that area is totally necrotized and there was no viable tumors. And also, this histotripsy can use when patient is under any kind of a treatment. This patient is colon cancer liver metastasis. The patient was sigmoid colon cancer. Unfortunately, 2 years later, patient developed a liver metastasis, and there was a multiple pulmonary nodules too. And the patient started in the first cycle of FOLFOX. The tumor was the right side and compressing the IBC. So main tumor is obviated to the right pedicle and also close to the main pedicle. This MRI shows the main knee tumor is located right posterior side, but also very close to the main trunk. As you can see that the tumor is compressing IBC. As I mentioned before, the patient has a bilateral lung metastasis. We did the histotripsy ultrasound that shows about the 10 to 11 centimeter size of a big tumor. The patient got the histotripsy last year, January. This is a patient position, and this is a resident actually helping me. And I did the 5 overlapping treatment. Because the tumor is, histotripsy only can treating about a 4 centimeter size in a single time. That's why we have 5 overlapping treatment to cover whole tumors. This is the post-treatment ultrasound. And post-op day 1, we routinely take a CT scan. As you can see, the tumor is necrotized. But this time, we didn't treat the whole lesion. We only treated partially because as you can see that the patient have already lung metastasis. So we sort of cytoreductive treatment we did. And 1 month later, you can see the tumor is more smaller.
We have 90 minutes.
4 months follow-up CT scan shows the tumor is much more smaller. But still, the tumor is quite close to the main right portal veins. And thankfully, the patient, the lung metastasis got controlled. So tumor will recommend taking out the tumor. Some of the lesions notified, and right hepatic vein is exposed and encircled. And try to do the Gleasonian approach, but because of the inflammation, I couldn't do it. So we try to isolate the vessels. And transection was studied first. And right Gleason was encircled. And ultrasound was checked the opposite side. And we finished the right hepatic pedicle and finished the rest of our operation. So we can achieve the arterial resection. And after histotripsy, CA level was just spiked up, but gradually that decreased. And there was when the level was lower down, we did the operation for her. Still, there was about 20% of viable tumors. But until now, there is no evidence of a recurrence for 9 months after the right hepatectomy. Unfortunately, patients have still small lung nodules, and CA was mildly elevated. So this treatment have some histotrips have some potential for the local control of colon cancer liver metastasis. This is a pre and post. So reason for the unresectable unresectable lung mets with the small lung metastasis, even for this kind of situation, the liver resection still have a better survival outcomes. So in conclusion, variable minimal invasive surgical option is available, previously considered not indicated for the minimal invasive liver surgery. The hepatic artery infusion pump provide the conversion and the bridging treatment for the transplantation. And histotrips is a non-thermal ablation and with a minimal complication. And that could have some potential for the advanced colon cancer liver metastasis and bridging to resection and transplantation. This is our team. We cannot do it by ourselves alone, so that's a whole team effort. So are you ready for the Bannister's effect?
Good morning, everyone. My name is Kwan-Woong Kim from Donghwan University Hospital. Today, I'd like to share our experience with the robotic, the application in highly complex liver surgery. So I have no COI. You can take a picture. And, the minimally invasive liver surgery is rapidly expanding. Now, in many centers, clinical outcomes are comparable to open surgery, but there is still a limitation. The highly complex cases remains very challenging. So today, I'd like to discuss how we can safely apply the minimally invasive surgery to these difficulty area. So today's key question is, can minimally invasive surgery be safely applied to highly complex liver surgery? So what is highly complex liver surgery? The first, the advanced cases based on the UAT score. Second is major hepatectomy. Third, the tumor in the posterior superior segment, such as S7, S8, S1, and S4A. And finally, cases requiring vascular or biliary reconstruction. So the concept of minimally invasive liver surgery has evolved step by step. In 2008, the Louisville statement established the feasibility. In 2014, the Morioka consensus meeting emphasized that the major cases require expert centers. In 2018, the Southampton guidelines showed that the complex surgery is possible in expert hands. And more recently, the robotic consensus meeting expanded these indications to even more complex cases. So based on these previous consensus statement, we can summarize the three key messages. First, safety is established. The second, the expertise is mandatory. The third, stepwise progression is essential. So complex liver surgery should be performed by experienced surgeon with a stepwise approach. So then, who should perform the complex liver surgery? It depends on the level of complexity. For each cases, any trained surgeon can perform them. For intermediate cases, they should be performed by experienced surgeon. But for highly complex cases, they should be performed by expert only. So as complexity increases, a higher level of surgical expertise is required. So then, which platform for highly complex cases? As you know, the laparoscope has clear limitations, but the robotic platform overcomes these limitations. So the robotic platform expands what is technically feasible. So why choose the robotic platform? I think first, it shows better outcomes with low conversion rate and less blood loss. And second, it is more effective in difficult segment. And third, it has a shorter learning curve, although the cost remains a limitation. So the robotic platform is not just an alternative, it expands the range of complex liver surgery. So next, let me briefly share our experience. We have performed over 200 robotic HPP surgeries, including living donor hepatectomy and PPPD and HPD cases. Importantly, we have also applied this approach to highly complex procedure and then open conversion rate, just 4 cases. So our experience has progressed step by step. We started a minor procedure, then moved to the major hepatectomy, and gradually advanced to the complex cases, including biliary and pancreatic surgery. So now we are performing major hepatectomy with biliary reconstruction for perihilar cholangiocarcinoma, including vascular reconstruction, and we also do the various single port HPP robotic surgery. So based on this stepwise progression, we have gradually expanded our indication by fully leveraging the strengths of the robotic platform. Here I will show you 2 advanced biliary procedures. First is ductoplasty for easy anastomosis. The second is hepatic jejunostomy. So these procedures are technically very demanding, so especially in a laparoscope setting. However, the robotic platform enables more precise and controlled reconstruction. Let's move to the bleeding control. In complex liver surgery, bleeding is inevitable, but with the robotic platform, we can control it safely and precisely. This is the common trunk area. When I dissected this area, I punctured the medial hepatic vein trunk. So at that time, I used the 4-0 mono barbed suture. There is no need to tie, so it is very effective to control the hepatic vein. So this is the right hepatectomy and S1, the bile duct resection cases. At that time, I injured the IBC, so I applied interrupted suture. At that time, the robotic platform is more effective to control the bleeding area. And then finally, here I will show you portal vein wedge resection combined with major hepatectomy. These are among the most technical demanding procedure in hepatobiliary surgery, especially in laparoscope approach. They are extremely challenging cases. So this is a left hepatectomy for the perihilar cholangiocarcinoma. At the time, the tumor invaded the left hepatic vein, so I cut the wedge of portal vein and the primary repair. This is a right hepatectomy stated. Before surgery, I performed the right portal vein embolization, but the coil is dislocated at the bifurcation area. At that time, I cut the right hepatic portal vein and remove the coil. I clear portal vein margin, so primary repair. And next, I will show you several video clips of complex robotic liver surgery. These include the major hepatectomy, the posterior superior segmentectomy, and donor hepatectomy. So this is an S4A wedge resection. This area deep and close to the diaphragm and close to the major hepatic veins, so it is very challenging in laparoscope. But the robotic platform allows precise and stable dissection. This patient has the hepatic adenoma, the maybe 8 cm right here, so marked resection line. So I apply the total Pringle maneuver intracorporeally, and also the parenchymal dissection using the robotic harmonic scalpel and a bipolar instrument right here, like this. So this is a S8 vein. Carefully dissected the major hepatic vein. This is a middle hepatic vein trunk. This is a short, small Glisonian pedicure to the S4A. Clip and cut. This is a left hepatic vein. This is a full middle hepatic vein. Now I move to the left side. You can see the left hepatic vein here. So this is a final view of S4A wedge resection, and you can see it very clear, the major vascular anatomy here. So post-operative finding, there was no specific complication. So for the right posterior sectionectomy, patient positioning is very critical. So yellow line is indicated the posterior section plan, and the blue line indicated the right hepatectomy plan. In supine position, the posterior section plan is the oblique is and also difficult. So, but in full lateral position, the plan becomes aligned and intuitive. So this plan provides a view similar to the right hepatectomy. So changing the patient position transformed the difficult procedure into a more straightforward procedure. So this slide shows our port placement and a patient position. The port are aligned parallel to the costal margin, and the patient position is placed in a full lateral position for right posterior sectionectomy. This video clip is right posterior sectionectomy. As I mentioned earlier, the patient position in the full left lateral position. So the surgical axis changed. So now I cut the caudate process first, and then I dissected the right posterior, the Glisonian pedicure. There's a tape and hemorrhagic clip applied and cut. So I checked the demarcation line here. Maybe the posterior glison is the S6 segment is main. So this is a tumor. So tumor is very close to the peritoneum, so I mobilize the right rope with peritoneum like this. So this is IBC. This is so recheck the transaction line, and I applied the rubber band technique, and I started the parenchymal transaction. With the patient position, our the transaction plan became more intuitive. You can see the provide very similar to that right hepatectomy. So proper alignment, the camera and the transaction plan is essential for the safe and effective liver resection. This is a final view of right posterior sectionectomy now. This is a caudate lobectomy using SP platform. This procedure is very challenging due to its deep location and proximity to the IBC. So the laparoscope setting, it is extremely difficult, I think. But with a single port robotic platform, it became feasible, and it shows, I think, the future potential of robotic surgery. So this, maybe this video clip has been presented multiple times at the previous meeting, so I will skip it.
Single port.
This is a final complete caudate lobectomy. This is caudate process and Switzerland lobe and the IBC. And this slide, Klatskin tumor case, it requires major hepatectomy and complex biliary reconstruction. So it is technically very demanding and extremely challenging with the laparoscope approach. However, the robotic platform provides better suturing and more precise dissection in hilar area, so and enables this level of ultra complex surgery. Due to the time limitation, I cannot present all the detail for the perihilar cholangiocarcinoma. However, I'd like to refer you to these video articles for more comprehensive understanding for the Klatskin tumor. And also for the same reason that I cannot show that the entire donor hepatectomy procedure. However, you can refer to this unedited expert video clip for the full details. Since this topic will be covered by next speakers, I will not repeat it here. So in conclusion, the complex liver surgery requires expertise and a stepwise approach. This robotic platform helps us to overcome the limitation of laparoscope approach, and also allowed us to safely expand into more complex procedure. So robotic platform is just a tool. It is a way to redefine the limit of minimally invasive liver surgery. So before I finish it, I hope to see you all again at the upcoming APH PBA 2027 in Busan. Thank you for your kind attention. Thank you.
Thank you for the kind introduction. I don't know if I'm the right person to talk about this, being in a room with so many experts here, but I'll try my best. So I have no financial disclosure. What I want to start with is if we talk about surgical technique, how to become standard of care, then surgical innovation follows a scientific pathway known as the ideal framework, which starts with 4 stages. Stage 1 is always the proof of concept developed by pioneers when encountered with a surgical problem. And then the second stage goes on about the efficiency and safety of this procedure. And this is usually known as the development or the exploration stage, where small series to large series are published to demonstrate the safety of this procedure. In the third stage, then comparisons are made with other techniques, usually the standard of care procedure at that point. And those are usually comparative studies. The best known are RCTs. And before it becomes a standard of care, we have to have a long-term quality assessments. And these are usually done by registries. So living donors is also such thing. It started in the late 80s when encountered with the cadaveric organ shortage in pediatric patients. And two surgeons on different places in the world developed the living donor left lobe or left lateral segment donations to pediatric patients. This is bothly done in the same time, so nobody actually knows who was the first. But this is actually the start of living donor donation. And then soon afterwards, Professor Makuchi in Japan in '93 did the first adult-to-adult living donation using a left lobe graft, which is actually an expansion of a left lateral graft. And not long after that, many Asian centers, whereas Korea, Japan, Taiwan, and also Hong Kong came together to discuss about living donation with main issues of donor safety and graft quality to have an adequate liver function after liver transplant. And this was known as the 5-center meeting in '96, the first one being in Taiwan. So I'm not going to go through everything in living donor, but there are some important pioneers and landmarks in the beginning in the 1990s, with Makuchi starting with the first graft. But the Cantonese group, the Hong Kong group led by S.D. Fan, soon followed up with right lobe grafts, including the MHV. The ASAN group then developed the right lobe graft without MHV, but with segment 5 and segment 8 reconstructions. And because of donor safety, they also developed dual grafts, which is still being used. And then later, the Japanese group found ways to overcome small for size syndrome and small for graft. And if you fast forward today, you know, this is really a standard of care now, with many publications and also many registries to determine the long-term outcome of living donor. So this is a world map of all the living donor centers in the world. And as you can see, Mongolia is actually the leading center in transplant rates for living donations, shortly followed up by Korea and Turkey, but it's now a standard of care in most of the world. And in terms of number, if we want to talk about numbers, then we should look at this graph. There's about 42,500 liver transplants done every year with an annual increase of 3%. And about a quarter of these liver transplants are actually living donors. So these are no small numbers. We're talking about 10,000 liver transplants using living donors as grafts. Now, what are the surgical outcomes? And this is a very good paper, a meta-analysis compromising about 61,000 donors, and the complication rate is about 25%, with a low major complication rate of 5.5%. And unfortunately, the donor death rate is still an issue with about 0.06% chances of donors dying after this operation. Remember, these are healthy people. Fortunately, this death rate has been in recent data, especially from the A2AL registries, has dropped well below this target. But when you look closely at the types of complication, and one can see that the major issues are mainly psychological and wound-related issues. These are healthy donors, and we know we often say that minimal invasive surgery is not about the wound, but in healthy donors, this is different. If you look at the risk factor analysis in this nice paper on meta-analysis, then one can only say the major depression rate is mainly found in Western and East Asian regions. It's less pronounced in Middle East and also in Western Europe. And the risk factors are usually young women who are unemployed with a low educational status. And perhaps the scar leads to less chances of getting married or finding a suitable partner, which may, in my opinion, lead to mental issue states. So we do have to think about wounds, I think. And looking at MIS and donor hepatectomy, the same evolution started in the 2000s with the French group led by Denis Jaekeun, also in pediatric population, using laparoscopic technique to harvest the left lateral segments. And this was then safely adopted with hand-assisted, first in America, and then fully laparoscopically in 2013 by Olivier Soubran in France. And then afterwards, the Korean nation adopted this technique, and there was a Korean storm of publication from many high-volume centers using laparoscopic assisted and full laparoscopic donor hepatectomy. It's now really become a standard, also thankful to the innovations in laparoscopic surgery with better resolution, ICG, and even 3D view, that this has actually now become a standard of care in many centers. Now, what about the wound satisfaction rate? This is a nice study done by the National University in Seoul, where they compared two groups of open, one with an L incision, one with a midline incision, to the full laparoscopic group. And as you can see from the results, the full laparoscopic group had a better cosmetic and image satisfaction with the scars, but more, their confidence rate was also increased, so they were actually more confident after undergoing laparoscopic than open procedures. How about the robot evolution? That happened 10 years later, started in 2012, but as you can see, it's a very rapid evolution. Within a time span of 5 years, many centers were doing this, also because maybe of a less learning curve. And this has also led to the first robotic liver transplant, which will be presented by my next speaker, the basis for it. So now it's also worldwide adopted, and recently it's also been reported of single port use for robot donor hepatectomy by the Riyadh group. Now, there was also a comparison on wound complications of wound satisfaction rate, laparoscopic versus robot, and here we see that in the robot group, the results were better, but in terms of confidence rate, there was no actually much difference between the both minimally invasive techniques. Now, if we want to talk about surgical outcomes, then this international registry, which was recently published, comprising 62 institutes and 2,600 living donors, show that robot group had less blood loss during the operation, less hospital stay, less pain, and less morbidity. And if you compare the three groups, the robot group was obviously better, but the laparoscopy, which was surprisingly worse of the three groups in major and overall morbidity. Even in multivariate analysis, the robot came better. Now, this is another study, a single center study from Riyadh. I think it's the largest study so far, comprising about 3,450 cases. I think most of you know this paper. And they showed on multivariate analysis that robot was actually better, but also laparoscopic compared to open. So this is a bit conflicting from the registry. But not only that, also in the recipient, the robot donor hepatectomy led to less complications. Now you may ask why. And the reason behind that is because of the better vision and better enhanced movement. You can actually transect better the bile duct, thereby reducing the number of bile ducts. And this led, in the opinion of the author, to less biliary complication in the recipient. Noticeably, the MIS group, so laparoscopic and robot, had less bleeding complications versus the open, which is also well known. Now, what are the risk factors for complication in the laparoscopic group, donor hepatectomy? This is the only study I could find, comprising of 8 studies, and they show that the risk factors for complication in the laparoscopic donor hepatectomy is actually based on the graft size and the number of hepatic veins, but also the size of the bile duct and how far it's transected from the confluence. Now, given the current state, if you look at this map, all the white dots are the centers doing living donor, as you've seen before, but the red dots are the centers where they do MIS. And as you can see on this graph, there's an exponential increase in the MIS centers doing donor hepatectomy. And if you ask those MIS centers what do they prefer, black being the robot application, then there's more and more robot applications versus laparoscopic. And if you ask the centers that don't do MIS, the reason being number is because they don't have the experience in MIS. So most transplant surgeons are not actually MIS trained. So that's important. We often hear that financial reasons are a major reason why we don't proceed to MIS surgery, and this has been only true in about 9.5% of the cases. So we started our program last year in September, did the first A2A robot donation. This is our couple, a nephew donating to his aunt with PSC, and it's been a real success. We're going to proceed to our fourth case this year, hopefully. So there are a couple of major trends going forward which I think will help the robot surgery, and we've heard a lot of talks. One of them is AI automation, advanced imaging telesurgery, as we heard yesterday in the keynote lecture, the improved haptic feedback, which is already available in DV5. And I think in the future also semi-autonomous procedures like flying a plane where you put on autopilot and the surgeon sitting beside, such as suturing. And as robot platforms expand, I think there will be broader applications in training, and telesurgery is definitely a new innovation to come in the future. So I come to my conclusion. I think robot donor hepatectomy will soon proceed to stage 4 as a standard of care with better outcome, and this better outcome will lead to improved outcome also in the recipients, which further will reduce the health cost. I think the beneficial impact of MIS needs to be further explored to relationship to the mental status in the donors, because that's still a big issue in my opinion. Anyway, thank you for your attention.